Hello.
Hi.
Hello, and welcome everyone.
Hi.
Hello.
Good afternoon, everybody. We will begin in just a few more minutes. If you could just put your name and your organization in the chat, and we will be with you shortly. Good afternoon, everyone. We will begin in just a few more minutes. If you could, please leave your name and your organization in the chat box. We'd really appreciate it. Also, with this being the Learning Collaborative, sometimes there's issues with people's webcams and slowing down the web, for people that are in rural areas. Sometimes it makes it so it's difficult for them to continue on the presentation. So we'll just keep it without the webcams on, except for the person presenting. They're welcome to have it on. And it looks like we have about 30 people on the line now. So we'll start, and I'll give it one more minute and then we'll get started. Okay, so for today's Learning Collaborative, we are going to be talking about pharmacy and prescription drug monitoring and how to implement pharmacists into your program. So we will get started. And if you haven't already, to put your name and the organization in the chat. You can go to the next slide. And I'll just introduce myself. I'm Diane Halo. I'm the program director, and I will turn it over to Sam and the practice transformation team.
Sam Wardell, Director of Practice Transformation. And I'll turn it over to Martine.
Martin Sanchez, Practice Transformation Navigator. Laurel.
Hi, everybody. This is Laurel. Excited to be here this afternoon with you, and thanks for being here. Practice Transformation Navigator. And also I'd like to pass it on to Brittany.
Good afternoon, everyone. Thanks for joining us on your Friday afternoon. Brittany, I'm a Practice Transformation Navigator with Greater Columbia.
So this is Martine, and these are the sites that he works with. So Martine?
Yep. So these are the sites that I'm assigned to, and I have seen some of my some participants from my sites. I've seen Lisa Noble from Lords. She's the pharmacist. Kevin Taylor, Dr. Kevin Taylor from Lords. Michael Clement from Merit. Samantha Federick from Quality Behavioral Health. We have Tori Nebel, Kim Emery, and Minnie Smith from Columbia County Health Systems. Thank you guys for being here in this learning collaborative.
And these are the sites that I'm working with, I have the privilege to work with, and I see some of you out there. Thank you so much for joining. Michael Boatman is here from First Step. I've also seen Matthew Kemple from Lutheran Community Services, and thank you for joining Terry from Catholic Charities. I appreciate you guys making the time to join us, and really do appreciate all the work you're doing, and hopefully you'll find this time with us worthwhile today.
All right, and these are the sites that I have the pleasure of working with. Thank you guys for joining. Cheryl Boffman from Astria Sunnyside, Deb Watson from Pullman Regional Hospital. Just really appreciate you guys being able to join today. I know that it's a Friday and we're back into COVID, so I really appreciate everyone taking the time to be able to join us today for this learning collaborative.
So for today's agendas, we're going to talk about medication management, and then we'll have a panel discussion as well as a discussion with those on the line today. And then we will have time also for questions and answers. Next slide.
The medication management overview. The process of identifying the most accurate list of all medications that a patient is taking, including the name, their dosage, frequency, and route, by comparing the medical record to an external list of medications. And these are over-the-counter as well as prescribed. They are obtained from the patient, the hospital, or other providers. In that transition of care, that's the most important piece to make sure that we are still doing our medication reconciliations. It's the movement of a patient from one setting of care, hospital, ambulatory, primary care practice, ambulatory specialty care practice, long-term care, home health, rehabilitation facility, into another. This is the definition that is actually CMS provides on their websites and underneath all of their metrics. Next slide, please. So CMS Services actually has a CPT code 111F, and the medication reconciliation is conducted by a prescribing practitioner, clinical pharmacist, or registered nurse on or within those 30 days of discharge into an ambulatory setting, meaning that this is not a reimbursed code. Initially, when they first set out the code, there was a $10 reimbursement just for an introduction into it to make sure that it was a process improvement plan. Again, it is used by CMS Services in order for them to track medication reconciliation. So really need to be putting those on your HCFA 1500 forms to make sure that they alleviate any doing audits for the medication reconciliation. That is one way that they actually track them. And then there's some mandates at the bottom that are listed. Meaningful use, the Senate Bill 1254 around hospital pharmacies, the MIPS, Hedis, CAPS, and then of course the PCMH certification are just a few of those. Next slide, please.
All right, so this is actually being pulled directly from your guys' workbook. So we have a couple of different options that we want to talk about today as far as medication management and how you can implement it within your practice. So the first option, option A, that I'll be discussing is the part where the practice has integrated a clinical pharmacist or pharmacists into the care team. So this is a fully integrated pharmacy role. And they are responsible for the list of the following. So they work on site with the care team. They're involved in patient care, either directly or through chart review, and offer recommendations and document within the EHR that the provider care team does. They participate in the identification of high-risk patients who would benefit from medication management. They participate in the provider care teams and in the meetings. And then they also participate in development of process improvement for medication effectiveness and safety for each patient. Ideally, they would also be MAT trained, clinical or referral source identified, and then also using the PDMP to monitor the prescription medications that your patients are taking. So this is kind of ultimately, kind of the gold standard that we would like to see. Obviously, this is not always practical for every practice, especially for some of our smaller practices. But we do have some of our larger practices that are doing this and is very effective. So hopefully we'll be able to go ahead and during our discussions, we can talk a little bit about some of the sites that are utilizing this option for their medication management role. Like I said, there are a couple other ones. So the next option is right here, and I will hand it off to Laurel.
So just like what Brittany was saying, this is pulled from our reporting. So those of you who recall a toolkit that we gave out to kind of help you understand what practice transformation is all about and how the goals that we want to be working towards. So this is the option B of 3 options that are explained in the toolkit. And you'll also find parts of this when you look at the, when you go online on the portal and click on reporting, and then you are in milestone B, and at the very bottom, you look at medication management. You get to choose, maybe some of you who do the reporting here actually know that you choose option A, B, or C. So A, what Brittany just talked about, like she said, it's the gold standard. It's, we all wish we could have that. Many organizations can or cannot for various reasons. But this option B, it's a lot of the same things that we discussed with option A. But while those comprehensive medication management services are being provided to the patients that you serve, they are done with perhaps, not an embedded, like physically present in the clinic, but maybe if you're a clinic that you have a pharmacist at the hospital that it helps provide the services, or maybe you have a collaborative agreement with a pharmacist that you're doing these comprehensive medication management services. But with that same focus as always on our patients, these things that we are doing under option B are things like the medication reconciliation. We're gonna, all of you know about this, and I know all of you have heard about it, and many of you have been doing it and doing it well. We're gonna talk a little bit more about that later in our Learning Collaborative today. But one of the things in this model with option B is medication reconciliation, the coordination of medications across transitions and care settings. We know that's so important. So that's one of the focuses, maybe using a nurse care manager to do that, or a pharmacist. That's accomplished in different ways in our multiple provider settings. a medication review and assessment aimed at providing the safest and most cost-effective medication regimen possible to meet the patient's health goals. Development of a medication action plan or contribution to a global care plan. So it's not just a med and you go pick it up at the pharmacy, but discussion as part of your care plan and where that medication fits in. Medication monitoring. We're checking with those patients to see how they're doing. Are they still taking it or really taking it every day? Or if not, why not? So monitoring that in some fashion. Support for medication adherence and self-management, what I just talked about, but stated in a different way on this bullet point. And then collaborative drug therapy management when it's within the scope of practice, like if you're able to do that, depending on the drug therapy. Monitoring of the PDMP part and parcel with the importance of making sure that you understand whether this patient historically has been prescribed or maybe they're currently being prescribed from another provider by checking the PDMP. And then the MAT-trained clinician or referral source as being identified. So, maybe you don't have a MAT-trained clinician as part of your team with this model, but you have a consistent clinician or referral source identified and working together, collaborating together to ensure that the patient's needs are met. So that's kind of an overview of what we're looking at with this slide. The option B of A, B, and C. And I think we'll go ahead and go on to C with Martine. And then after that point, if you have questions or if you want to make comments, we really would welcome them.
Thank you, Laurel. So this is the option C that is in milestone 2 under medication management in the Greater Columbia CARES model. So that's the toolkit that Laurel and Brittany mentioned previously. So this medication management option C allows the practice to have a systematic approach to the identification of patients that need medication management services that are active patients of theirs. The different, the criteria for this specific option C include patients in high-risk cohorts already identified under milestone 2. So this can be the patients that are identified through your risk stratification methodology that is in milestone 2. The other criteria are patients who have not achieved a therapeutic goal for a chronic condition, patients with care transitions, patients are systematically referenced in the PDMP at each visit and prescribing episode, patients with multiple ED visits or hospitalizations, patients with high-risk medications or complex medication regimens, and the practice measures key processes and outcomes to improve medication effectiveness, and safety. So this is what the criteria for option C under the medication management piece in milestone 2, which allows some flexibility and some some freedom to still be able to accomplish medication management. Although for sites that select option C might not have a pharmacist on site or that's part of their system, they're still able to complete medication management through by fulfilling that criteria under option C in the Greater Columbia CARES model, medication management milestone.
So would anyone like to have a comment, make a comment, or have a question about these 3 options, or any questions? If we did a quiz, do you know which one you guys are using in each of your organizations? We're not going to do that. Just kidding.
So Laurel and Practice Transformation Team, this is Carol. So I'm just wondering, I know that we have heard how successful it has been embedding a pharmacist into the care team. And, I didn't know if that's part of the panel presentations, if that's what they're going to talk about, but I just know that I have heard many great stories of those pharmacists who are embedded in the care team and what a difference it has made.
Yes, Carol. So that is one of the we are going to be talking about that, but just to give a little bit of information before that, there are sites that have a pharmacist integrated as part of their care team, and there has been, I can tell you that for my sites, Lord's Health and Columbia Basin Health Association in Kennewick and Othello, they have a pharmacist as part of their system resource, and they have seen good outcomes because of their involvement in patient care.
Thank you, Martine.
And if Dr. Taylor and Lisa Noble, you guys wanna share some of your insights of how you guys are doing medication management and doing the integration of pharmacists, we would welcome your feedback as well.
Hi, thanks, Martine. This is Lisa. I just wasn't sure if I can comment quite a bit, but I wasn't sure if you were going to talk more about anything or if you wanted me to start commenting right now about what I'm doing and what we're doing as a team.
Let's go through the panel presentations, okay. And then right after our last presentation, Lisa, if you can share your insights with us, that would be great.
Yeah, no, that sounds great. Thanks.
Thank you so much.
Mm-hmm.
You can go to the next slide. So these are the questions that we had asked our panel to answer as we're going through. But I also want to pose this to anyone who's in the audience that wants to answer these questions as well. So basically the question is, how are you integrating a pharmacist? What is your method of collaboration? What's your current process? Is it immediate team members involved in the process? And what are the other processes and skills that you would be using as in motivational interviewing, decision aids, or other evidence-based practices? And then how do you do the medication reconciliation through the EMR system or access the PDMP manually? So we'll go ahead and go to the next slide.
Diane, Martine posted those questions so that the audience can keep those in mind, that those are questions for the panel so that we're not duplicating efforts of the same questions there.
Thank you, Sam.
Thank you, Dan.
Yeah, go ahead, and I'll let Martine introduce his speakers.
Yes, thank you. So our first speaker comes from Columbia County Health System. They are actually one of my sites that I've been working for the past 3 years, and I've had the pleasure of working with Kim Emery. She's a PA. She's the Director of Clinical Services, and a little bit of background on her. She grew up in Memphis, Tennessee, and moved to Washington in 1977. She spent her first 20 years in healthcare in the lab and doing lab work. She was always interested in patients. What is the treatment? How can we help them? And so she went to the University of Washington Medical School to the MEDEX Northwest Physician Assistant Program. After school, she worked at a couple of University of Washington neighborhood clinics. There, she divided her time between managing the clinic and seeing patients. She migrated to the east side, Dayton, Washington in 2012 and began seeing patients at Columbia Family Clinic. She's honored to be working for an organization that cares so deeply for our patients and our community. And over the past year, she has directed her focus and is now the Director of Clinic Services. She works closely with our community pharmacists, their community pharmacists, to care for their wonderful community of theirs. Kim, the floor is yours.
Hi, and I also brought with me Tori, excuse me. We have lots of Jories at our institution, but Tori is a pharmacist who works with us. And probably for the last few years, we incorporated our community pharmacist to work with us. We are a little bitty town, one stoplight. We have one pharmacy, and we work very closely with them. And so in working so closely, now Tori comes once a week. We have 2 clinics. So 1 week he comes to one clinic and 1 week he comes to the other clinic. We give him names of patients that he helps us with. We have a palliative care program. So sometimes he goes to the homes with a palliative care nurse, which is always eye-opening to see how many bottles of pills are hanging around and when they're from and how many people take a pill daily, yet the bottle is still almost full, and all those things that I'm sure everybody experiences. So we're trying to help our patients so that they can be on the best medicines and the ones that they can afford. That's another thing that he helps us with. So he works closely with all of us as providers. He works closely with our nursing team, like I said, with our palliative care team. And going through our charts, he documents in our charts. He gives us information of maybe this would be a better medication that you should try for this patient, or this is one that's affordable and this is what it can do based on the needs of the patient and sometimes the needs of the caregivers, because we all know that the caregivers help with the patient care as well. And so I'm going to let Tori speak for a couple of minutes because he's the one that actually does it.
All right, thanks, Kim. Can everyone hear me?
Yes.
Okay, great. So yeah, that was a broad overview of kind of my role here at the clinic. Like Kim said, it's been typically on Fridays, I'm here for half the day, alternate between clinic to clinic. And like Kim said, there's one local pharmacy. I'm also a pharmacist there. And I think it's a really good way to just close the loop. I'm here, I'm able to see what patients are actually getting filled at the pharmacy on a regular basis. I'm able to see, what copays are, if cost is an issue, trying to figure out alternatives there. Just getting out in the community, going to patients' homes, seeing them here, really working on those transitions of care when someone's either discharging from a hospital or in our chronic care management program, palliative care, a lot of ins and outs and moving around. So tracking down medication lists from multiple providers, getting fill histories from pharmacies, trying to put that all together and then contacting the patient last. So I already have a good idea of what's going on. And then really just going from there. Education, motivational interviewing, like you said, is a big thing, trying to get the patient to buy into their treatments so they really see value and we're all on the same page. That's been very beneficial. What was another question here? Oh yeah, documenting in the EMR. Recently, I think we have the availability to access the PDMP, but currently I'm just manually doing that. If there's ever patients that I need to be checking that on, so manually doing that, documenting, and being just the small organization that we are, it's nice to have a lot of face-to-face interaction with the providers, with the nurses. It's just easy to talk to each other when I'm at the drugstore, give me a call there. And so we do a really good job of communicating that way.
Thank you. Any other questions that anybody has for us?
All right, thank you.
Yep. Thank you, Kim and Tori, for that. If there are any questions, there is a slide or some time saved just for questions. So if you guys don't have any questions just yet, just kind of think about what you just heard. And if any questions come up during any of the presentations, please write them down so you don't forget, or just remember them real good. And we will have the chance to ask those questions here at the end of the panel presentations. Okay, next slide. So next up, we have Sundown M Ranch. They are a substance use provider, inpatient out of Yakima. And we have Emily Hodson. She's a medical assistant for Sundown M Ranch. And we also have Mark Lowe's, which is the director of operations. And a little bit of background on Emily. She is currently the medical assistant to Dr. Greg Raymond at Sundown M Ranch. Emily has been with Sundown M Ranch for 6 years, working in many departments. She has found her passion with treating patients for withdrawal from chemical dependency and advocating for patient care. Emily is currently a student with Yakima Valley Community College to further her career. Emily is also part of the SELA coalition group who strives to make SELA's youth a drug-free community. Mark has worked at Sundown M Ranch for over 20 years. He is currently the Chief Operating Officer. He is an active CARB surveyor and enjoys a collaborative accreditation process. Mark is a regular presenter / lecturer, sharing his behavioral health, clinical, and administrative experiences in a variety of settings. Mark is passionate about golf, sports cars, teaching, and recovery. At this point in his career, Mark's primary goals are to increase awareness and access for treatment, services, and to reduce the stigma of substance use disorder. Mark and Emily, the floor is yours. Oh, actually, next slide. We have some slides for Mark and Emily. And if you guys are talking, you might be muted, Mark.
Got it. Hey, thank you, Martin. Good afternoon, everybody. So our medical team is made up of Dr. Greg Raymond, who's an MD and also is board certified in addiction medicine and family medicine. Emily is our medical assistant, and then clinical supervisor and our medical room support staff. So residential treatment facilities are a little different in that we don't administer medication. So we do lots of medical services, but no 24-hour nursing. So all the patient medications are self-administered. So lots of support staff are part of the medical team because we're working in the med room managing, doing the medication management. Next slide. So there's a lot of resources, both subjective and objective, that go into our patient care model. So for the very first phone call, we're collecting information via an initial ASAM screen, which covers all 6 dimensions and actually collects quite a bit of information. That process is duplicated and enhanced with the face-to-face assessment, which is the biopsychosocial, which is generally done with a credentialed person, an SUDP or an SUDPT. During the first 24 hours or so, a medical assessment and physical examination is conducted. In many cases, collective medical is reviewed, the PDMP is reviewed, your analysis testing is conducted as needed, lab tests are conducted as needed. And of course, the subjective part of patient behavior, patient observation, and patient progress all goes into patient care decisions. And then on top of that, almost 100% of our patients were utilizing some form of decision aid in their care process. Next slide. So I think I'll let Emily jump in because Emily's really the glue that makes all this work. So Emily is the the conduit between, the administration, the clinical team, the medical team, and patient care. She is really the wheel that makes it all work, and she has all the details about how all of these cases work.
Hello, everybody. So referring back to where Mark left off, just an example of how that whole process would work is huge part of our priority every day is myself and Dr. Raymond. We go through the complete ASAM screen. We verify patients' medications, patient history, any high-risk patients. So when they arrive to our facility, we already have a idea of where we would go with their treatment, whether that be right away, looking up medications through the PDMP, getting on to collective medical as patients state several hospitalization stays. So we're able to kind of break that down and give them the care that they need. For example, we've had, a couple patients come in the past where, complaining of symptoms, and they've had several overdoses in the past, whether that be overdoses, where they're in the hospital for several days, gives us a better idea of how to give them that coordination support from hospital stays to inpatient stays with us. And whether that be through the PDMP, but we can access that daily and utilize that on our patients. And then of course they are assessed through appropriate, assessments in our computer system through myself, sometimes the med staff, the support staff in the med room, and we're able to give that feedback to our medical director to determine their care. And we do work fairly closely with our pharmacist. As Mark stated, our patients do self-administer their medications. So with that being said, getting that information to the pharmacy in a timely manner is crucial, whether that be our pharmacists looking at their demographics, making sure they have their correct insurance information, co-pays, all of those things play a huge factor in getting medications here to our facility in a timely manner so we can give our patients the best care. And I think I'm ready for the next screen. Okay, so the other thing that we talk to our patients about, kind of referring back to that first slide we looked over, is our medical director does talk to our patients about the medications that they're being, prescribed and managed on while they're here. We also talk a lot about MAT services to our patients, whether that's coordinating care between us prescribing them, patients coming in on medications. We are able to effectively manage their medicated assisted treatment services so they can continue that care with hopes of a little relapse. So that's a huge thing that we communicate to our patients on, is having that continued care, of course, meeting their individual needs. And it definitely does make for that better outcome in their recovery and just the well-being of their healthcare. So we have a lot of resources on referring them, managing their MAT services, of course, with our medical director, trained clinicians, works out very well. And next slide. And of course, last but not least, Sun Dunham Ranch, the patient is the reason we are here.
That girl.
All right, thank you. Emily and Mark. Next up, that is it as far as the panel presentations. If Lisa, you want to share your insights with us, that would be great.
Yeah, yeah, it'll be nice to talk with Tori too and get some of his feedback. So I work for Lord's Health, and I work in a clinic setting. So again, like we're talking about, the goal is to increase the quality of care for the patient. So, the team approach is just an ideal situation to work in. I work in the clinic. We have a small outpatient pharmacy. We're open to everyone, but it's a small pharmacy and it's low volume, so it helps free me up to work with these patients. I work directly with our wonderful nurse navigator, Sarah Lair, and then the medical director, Dr. Taylor, is very supportive too, with all of what we're doing. So I work mainly with Sarah, the nurse navigator, and then the providers. Right now, we focus mainly on patients. What we do is we focus on patients with diabetes and patients with depression. So what we do, I'll just walk through like an example, and then if people have questions, but how we've started doing this, and we're always trying to fine tune it, is we will get the doctors will have a patient, like a patient with diabetes, that they're struggling with, that's taking a lot of time, that's not meeting goals, that has a high A1C. Sarah has even gone through and like targeted patients with high A1Cs. And then that's how we kind of drill down what patients we're going to start with. And then everything goes through, we do it all through the EMR, and we document everything. It'll go through as a case. And then when it gets sent to me, I'll just kind of spend an extra time with the patient. I'll call the patient, the provider will, explain what they want done, what's going on, what's been going on, and what they hope to see. And then I will call the patient. And then that's where all of this comes in. I mean, like you said, there's one thing, you have the list of what the patient's medications are. You call the patient, you talk to the patient, you find out the patient isn't doing, what you're expecting them to do. And so then clarify what's going on there, try to get there. A lot of times I'll call, and with a diabetes patient, I can't even get they haven't been checking their blood glucoses. Some of them are good about checking their blood sugars, some are not. And so sometimes it takes, then I have to call them back, have them check and then call them back. So, sometimes it can be a quicker process and sometimes it's more entailed. But then then the motivational interviewing comes in, because you spend a lot of time just trying to get information from the patient to motivate them. And then after gathering all that information, I'll make a note in the EMR about what was talked about, and what my recommendation would be from a pharmacy perspective for the medication management. And then that is sent to the provider. And then that is all just recommendations. And then it's up to the provider then to look at that and decide, what they want to do with that. And then we'll go back and forth for follow-up. So it's worked well for a lot of patients. There's there's a learning curve, and still is. The hope is that these providers see it as when they have patients that are difficult and time consuming, my hope as a pharmacist is this will increase the quality of care to the patient, and also make it easier on the provider and kind of take a load off of them so that they can spend more time with their diagnosed, there's so much they need to be doing. And so hopefully that frees them up for, dealing with all kinds of different diagnoses with the patients and helping them. So anyways, if anyone has any questions or I've enjoyed it a lot. And I just think it's helpful to get as many team members, like you said, it depends on your practice setting, but it's helpful to get as many team members on board as possible to help with these patients. So.
Lisa, this is Laurel. I have a question for you. In regards to your relationship with the providers, how has this approach changed your relationship with them?
It has, in general, it's been very, it's been helpful, and it's been interesting because a number of the providers, a couple of them, I would say it depends on the provider, but they sometimes are like, oh, I don't need help with that, or that I can order the meds. And then over time, when they start seeing what you're doing, they, it's seen as a positive, and they like it, and then they come to you. And the nice thing about being physically in the clinic, it is helpful to be able to go talk to them face to face, and it does help a lot. And then they, they'll come to you more. It's interesting though, because some providers are still not utilizing, I think it's underutilized in general. And there's certain providers that will glom onto this and really like it. And then some providers I'm still not having much interaction with. So
Yeah, thanks for answering that, Lisa. I think it's so interesting because we talk about, and we all kind of, I think on the call, realize the value of team-based care, but how do you get there? Because even if you put all the people in a room, it takes time. So I appreciate your answer, and that like you started with one thing, but they don't really, it's like, what is she going to do anyway? Because we've had these traditional kind of roles that, no, pharmacists do this and not that. And I'm, the physician, and I do this, but not that. So to live into it a little bit, I can see, your answer is surprising to me, but also it makes sense. It's like, oh, okay, it takes a while. It's not a switch that you just flip.
Yeah. And it depends on the background of the provider, like what they've been used to or what they've seen. We just recently got we have some new providers in family practice at Lourdes. And they're, if you, it's nice to get them brand new, because then I can introduce myself, I can talk to them, and they seem, really open to it. It's just habits. It's not even really negative. It's just, you have a busy day, you have a lot of patients, and then all of a sudden, so say I'm the provider, someone comes to me and says, okay, you need to start, can you put cases into the chart, and you can ask for a pharmacist's help. But throughout the day, they're thinking, well, how do I go about doing that? And who do I send it to? And it's just changing, when you're changing your, what you're used to doing every day. So becoming.
And for our audience, Lisa, can you explain what a patient case is?
Oh, a patient case is just in the ENR. It's just a way that we communicate and document through the patient's electronic chart. So, yeah.
So like an electronic message that's part of the chart.
Yes.
Thank you.
Yeah, you're welcome.
I do have a question for all of the panelists, and you, Lisa, if you want to keep participating. And you guys have talked about it a little, throughout your presentations, but what would you guys say are your biggest, challenges when it comes to either, getting a provider to take advantage of the pharmacist, or engaging the pharmacist, or even engaging the patients? And what would be some of the successes that you guys have seen?
Well, this is Kim. I'll talk for a minute. I think one of, like Lisa said, we get used to how our day goes or how our office visit goes. But really, in these times, as we're trying to go more to team-based care, we need to open up a little bit and figure out who's the best at doing what, because that's the better way to take care of the patient. And sometimes it is hard to figure out, okay, how am I going to get them here? I can barely get them into the office. So how am I going to get them to either come back on the right day to talk to Tori, or how am I going to get them to answer the phone? Because we all know that some people answer the phone better than others. And so just getting that whole dynamic. But as we keep moving forward with doing more team things, like I don't have to be the one that does all of this, and I don't even have all of the knowledge to do some of this. Somebody else needs to help me. And as we keep promoting that, this whole team approach, and our patients then learn, I can go to anybody in the team and they'll direct me to the right patient. I don't have to, Kim doesn't have to be the only one that can do all this. Then it makes things better for everybody and better quality of care. And we can use all the evidence base instead of going, what did I learn 10 years ago and have I moved on since then? So I see this as something in the future, but we have to change some of our habits, because you get used to doing something and you go, oh, I really need to do it a different way. And we just need sometimes little prods like, remember, you were going to do it a different way. So I don't know what experience you've had, Tori, with working with us, because of course, everything starts off slow and then builds up. So that's.
Thank you, Kim.
Yeah, this is Tori again. Yeah, pretty much, I think you guys are spot on. It's just kind of getting out of that routine. Providers are overloaded often with paperwork and, seeing patients and everything else that goes along with that. And so just figuring out the easiest way to have a referral to pharmacy, or to get that conversation started, I think is the biggest thing. Just making it easy for the providers to utilize pharmacy services, to build that trust, that relationship. Like Lisa was saying, I mean, sometimes providers are used to their ways. They've done it this way for a long time, and now you bring somebody else in who's willing to help, but sometimes it's kind of difficult to get that relationship established. But overall, I think the providers here have been very receptive and will, push things my way if it's a time-consuming patient, or if there's medication in question, or wondering if best therapy for them. There's a better cost alternative for the patient. That's kind of a big one, especially me being in the pharmacy, where I can directly see what copays are, and look and see if there's a better alternative for the patient. So that's what I see as the biggest barrier, is just breaking routine.
Mm-hmm.
Martine, do you mind if I ask a question? This is Carol.
No, go ahead, please, Carol.
Thank you. This has been such a great conversation. This morning, several of us on the Greater Columbia team listened to a presentation by Insignia Health, and they use it's kind of motivational interviewing on steroids. It's the patient activation measure, and we're showing great results using this tool to improve their patients' level of engagement with healthcare providers. And I'm hearing you guys saying that, sometimes this is the biggest obstacle to a patient's health. And I've heard many providers say that compliance with medication is very difficult to deliver on. So I was just wondering if the pharmacists thought it would be helpful to have some of these kinds of trainings within Greater Columbia, so that we could share within each other's practices some of the best ways to motivate patients, since that seems to be, some part of your job, maybe not the biggest part of your job, but certainly as a pharmacist and trying to get your clients to comply with medications. I was wondering if something like that would be useful, or if you already get enough of that in your own trainings and practices that would be something that would not be of interest to you.
Well, from my perspective, yeah, I'm always open to new information. I feel like, I've run across so many different types of motivational interviewing, and a lot of it is just from experience and knowing your patient population, but I'm always open to that type of thing. So if you wanted to forward that information on, yeah, I would be open to looking at it. It's always helpful. So you can always glean things from the information. So yeah, I'm always open to learning new tricks.
Thank you, Lisa.
Yeah.
And Carol, this is Laura. I don't know if you know that we do have some sites that already utilize the patient activation measure. Anyone on the call that might want to share about that, I might offer this opportunity.
And just maybe a little bit of backdrop with that, in case even some of the Greater Columbia ACH folks didn't know about it, because this happened about 3 years ago, that we're doing a pilot project with 5 healthcare systems in Yakima using PAM. We saw some of the results today, and the cost, the return on the investment for using PAM, which is, I think, kind of a licensed product, was pretty significant. And Diane can attest to some of the results that we saw today, but about a $250,000 cost savings this past, I think it was over the year, which might not seem like a lot, but for the $30,000 that it costs to implement PAM, it was pretty significant.
Yeah, it was a really significant amount for a 1 year time frame, considering they only spent $30,000 in the fees up front. So yeah, there was a significant amount of return on investment.
And I think the most exciting thing was the number of patients that went from a level 1 to a level 2, that they really improved their engagement, which is really the goal, right? It's great to talk about your return on your investment, but if you can engage your patients and reduce those emergency room visits or reduce those inpatient hospitalizations, that benefits, everyone. So didn't want to leave that behind. Not just all about the ROI, but really the improvement in the patient's health was really significant and very exciting.
Yeah, so we'll hopefully we'll be able to share this information with everybody in the GCACH region through either a learning collaborative or through a leadership council. So that's what we're exploring here shortly.
Oh, that sounds good. Excellent.
Are there any more questions from the audience that you guys are eager to ask?
I have a question for Tori, actually. This is Lisa. Tori, how much time do you spend like online versus offline? And what, I wasn't sure what pharmacy you're at.
Yeah, hi Lisa. So I'm with Elk Drug in Dayton, Washington here.
Okay.
And how much time am I online versus offline?
Yeah.
As far as, spending most of my time at the clinic online. Of course, COVID has thrown a kink in in everything. Had initially planned on doing more in-person, you know, kind of those handoffs to providers, where maybe I'd be with the patient before they were seen and actually providing education and reviewing medications, making sure that that's all up to date before they even see the provider. But right now, it's primarily looking at patient charts and phone calls for the most part of my time when I'm at the clinic here.
Okay. Yeah, that's interesting because that's what we discussed before doing this too. We envisioned a room where I would be in person.
Oh, you fucking piece of shit. Wow.
And anyways, and we would do like a warm handoff to the provider. But with you know, with COVID, it has been really hard, you know, because then we were just doing more stuff over the telephone and stuff. So it's interesting. So
Yeah, exactly. That's the same thing that we had in mind, but that's kind of where we're at right now. Hopefully that can change in the future. I do think that the handoff would, well, I think just being in person face to face is always the best if possible, but
right, absolutely.
Yeah.
Thank you. Thank you.
Yeah, thank you.
All right, if there's no more questions from the audience, we can move on to the next slide.
So behavioral health and SUD providers, what can we do to create better partnerships with primary care providers? And this is to the panel as well as the audience. And the same question goes to the primary care providers. What can we do to create better partnerships with our behavioral health and substance use providers?
So this is Lisa again. So with our depression patients, we actually have a behavioral health counselor. We have a specialist in, and she works with our nurse navigator. So they can sometimes do warm handoffs, and but anyways, they're in the clinic with us, which is excellent. We even had feedback. I had feedback from a patient that had seen her primary care provider, and she recommended seeing, you know, a counselor. And so she was able to go and introduce her to the counselor, even though she didn't have an appointment that day. And she was able to get an appointment within like 7 days. And she just said that she felt so well taken care of. It just really, it's wonderful having all the team members together. And then also our behavioral health specialists will provide input after seeing some of these patients to our nurse navigator and pull me in, because a lot of times like they're not taking their medicines because they're antidepressant because they have side effects that they don't like, or they're afraid to get started on a medicine because they've, you know, heard about side effects. So anyways, so we're communicating back and forth in the you know, in the electronic medical record through these cases. And then also I can physically just go over and talk to our behavioral health specialist, or Amelia. And it's, you know, again, that team approach is just invaluable. So
Thank you, Lisa. That was wonderful. I see Teresa Quate. She has a response in the chat. Teresa, do you want to talk about that?
Sorry, it's actually TJ and Kim Nagreen here from Police Medical. I just forgot to change the name, but it's the Police Medical team. We have on-site health psychologists with Leslie Robeson, and that being able to have that relationship with our primary care providers has just been invaluable. Throughout COVID, when we look at dealing with substance abuse issues and just trying to address all the mental health challenges that are just everywhere right now. So that's been really helpful. And then this last year, we have done a half day a week having a psychiatrist on site and trying to do BHCM type COCM care, where you're working it very similar to like a chronic care management, but in a behavioral health care approach to it. And we just continue to see over and over and over just how valuable that warm handoff is, and having relationships and seeing providers being able to see each other as colleagues in the clinic. That's key to a lot of success. That's all I wanted to say.
Thank you. Kevin Taylor, can you talk about Dr. Kevin Taylor? So Dr. Taylor put in the chat, as Lisa had said, having the behavioral health person on site and actually enabling the PCPs to see the behavioral health specialists face-to-face with on-site conversation about patient needs as they arise is extremely valuable and important. Mark, I'm going to call on you, Mark Lowe's, if you can talk about your internship with your MD and how that whole communication process works, and then what you found value in.
Sure. So the medical team, Doc, M, and the clinical supervisors meet every morning, kind of discuss, their day, what the plan for the day is, discussing any more high risk or high need patients that need to be seen, high need patients that may be coming in. Generally, all of the people in withdrawal management are going to get discussed because they all tend to have relatively high needs. But that relationship, Greg's awesome. I mean, Greg meets with patients and then collaborates with the clinical team all the time. I mean, that's just ongoing process. It's just part of our culture. It's part of what we do every day. So I don't think, the project had us focus a lot on data, but the patient care side, I think that style has been there for really a long time. We just do more stuff now, a lot more stuff, a lot more primary care for sure. But the collaboration part between the medical team and the clinical team is kind of a long-standing part of kind of who we are and what we think patient care should look like. I think one of the things that people won't like to hear is that on the residential side, in a year, I probably get less than 5 referrals from primary care, and you're talking 2,000 patients a year. So that's still kind of I'm really glad, and I think it's awesome that we have behavioral health people in settings that we didn't before, and that people's behavioral health needs are getting met. But there's still kind of a gap in the referral process or collaboration between hospitals, primary care, and residential inpatient treatment. We just don't see a lot of referrals coming out of our own system. In fact, hardly ever. I mean, super rare to get referrals out of other parts of the system, out of the healthcare system.
All right. Is there anyone from primary care that can comment on that? Navigators, anyone you want to call on?
Oh, this is Kim. I'll comment. I guess I didn't, we need more information of who we can refer and where we can refer. Because when we have patients who need inpatient treatment, I feel like we have such a hard time finding any place. But then when you say you don't get any referrals, there's a disconnect somewhere. So there's a knowledge deficit in our area of who and what we can refer to where, if that makes any sense.
Absolutely makes sense. No, I think that's, yep, no, I totally get that.
So we'll have to get some more information so that we can fix that problem, because we have people that need services. We just need to know where to get them to and how, what's the criteria and how to go about it. So it sounds like we need to get some more education from you.
Sure.
And I can make that connection between you, Kim, and Mark. So after this meeting or on Monday, I will make that connection for you guys, so you guys can have those conversations.
Perfect. Thank you.
Wonderful. Anyone else have any more comments in regards to the partnerships between SUD, behavioral health, and primary care?
Sam, this is Carol again, because this is really at the heart of bidirectional integration. And just trying to figure this out and having these discussions is very helpful, I think, to us on the staffing side, because we're trying to implement these measures that the healthcare authority is holding our feet to the fire to implement. And so a lot of discussion around, a community referral system, wonder about how effective that would be, or if it's more about relationship building and opportunities to get providers together, or simply just is having a resource directory. Is that the secret sauce? I think everybody's looking for a silver bullet. I have a feeling it's a combination of all of the things that we've been talking about today. Having those providers on site so that they're known, as colleagues. But we'd just love to hear some thoughts from the providers about what Greater Columbia could do to encourage these kinds of collaborations and referral mechanisms.
This is Laurel. I just wanted to see if Melissa Adams might be willing to mention anything that she could share with us about the Blue Mountain Collaborative and how that's going for the Walla Walla area.
Oh, sure. Well, hi, everyone. My name's Melissa, and can everybody hear me okay?
Yes.
Okay, great. Well, we have on the Providence campus in Walla Walla, we've got a free walk-in clinic that primary care providers can refer to. It's also an agency resource from the community. So really anyone in Walla Walla County or the surrounding area from Milton Freewater, Columbia County, anywhere can walk in 10 to 6 Tuesdays, Wednesdays, and Thursdays. It's a workforce development project that we help co-found with Anchor Point Counseling and Walla Walla University and Walla Walla Community College. So at the walk-in clinic, the clinical staff is master's level students in clinical social work from Walla Walla U. And then we have behavioral health navigators that are bachelor's level social work students, and also then AA students at Walla Walla Community College from the Human and Social Services. And then we have a community health worker as well that sort of provides that case management aspect as well to the services. So that's kind of the walk-in clinic. We recently opened an outpatient clinic where we have students who either one completed her practicum at the walk-in clinic, and then another student is an associate level clinician. And then we have a part-time person as well. So we've got 3 clinical staff that take Medicaid insurance. And we recently hired an FNP who has 20 years experience in psychiatry to provide that medication management. She's got a DEA waiver as well. So That's a new thing. It opened up this week, and those are scheduled appointments. The free clinic at the Providence campus on 2nd and Walla Walla is a free service. So I'm happy to answer any questions. We opened in February of this year, and we just opened our second location in August earlier this week.
Thank you
That's
so
great
much.
to hear.
I really appreciate your sharing. I've heard, bits and pieces about that, and I know that that's a great collaborative effort that's going on in Walla Walla, and it's always a pleasure to hear, how you guys are thinking outside of the box to try to help your patients out, and I do appreciate that sharing. And it's neat to see how hard you try, and then that the whole community comes together to meet these needs. So thank you so much for sharing.
Absolutely. And anybody, if you have any questions or you want to talk to me offline, I'm at Providence in Walla Walla. You can give me a call there, or I can put my email in the chat, but I'm happy to answer anybody's questions. If you'd like to come and take a tour, anything, I'm happy to share any information that I can with what we're doing here.
Thank you. Anyone else like to share, or navigators, is there someone that you'd like to call on?
I think we're good to go, Sam, for our next slide.
Okay, thank you. So we had a request for the prescription monitoring program policy, the changes that will take effect on October the 1st, 2021. So prescribers writing a prescription for any controlled medication for Apple Health must check the Washington State Prescription Monitoring Program no more than 10 days prior to writing the prescription. So that is any prescribers writing a prescription 10 days prior to writing that prescription. Pharmacists will be required to check the PMP no more than 48 hours prior to or after filling the medications. The healthcare authority is adding these requirements to the provider guides, and there'll be more implementation processes that you can find on the resource page that Laura will go over in just a little bit. These checks will not stop or limit opioid prescriptions. The prescribers and pharmacists must review all current prescriptions documented in the PMP. Prescribers and pharmacists may delegate this PMP review to authorized staff if they review all current prescriptions. Prescribers and pharmacists must review the patient's history and document date and time in the patient's record. If unable to access the PMP after a good faith effort, they must document this patient records with intended follow-up action. A healthcare authority is going to measure qualified checks performed by prescribers and pharmacists and or their delegates. A qualified check will be measured by matching date written on prescriptions in claims data with PMP data. Healthcare authority uses these claims to identify the date filled for that prescription, and the data will reflect whether any pharmacist or their delegate checked the PMP within that 48 hours of the date filled. And there's also resource pages available at the end of this presentation that goes over the complete healthcare authority, their presentation on all the required changes, and it gives more detail around this. I'll turn it over to Laurel.
My apologies, I was muted. We put this slide in just because we wanted to give some real practical pieces of advice or offer best practices we talked a little earlier about medication reconciliation. and the importance of doing that for patients for many reasons. So when we think about medication reconciliation, traditionally, and we kind of mentioned like those traditional roles of a pharmacist and then a provider, but this even goes into, thinking about our care teams and how different things have been done traditionally in this care setting. So more traditionally, you would see, for instance, a medical assistant performing the medication reconciliation during rooming. So, the third bullet point down here talks about decoupling medication reconciliation from rooming tasks. You have such a limited amount of time for a patient to come in and actually be seen with the provider. And so by moving that medication reconciliation from the rooming and moving it more towards an advanced plan, like having registered nurses, we've talked about care managers and their role in connecting a pharmacist with the patient to go over medications prior to. So just thinking about starting the process before the patient ever arrives, not just with medication reconciliation in particular, not waiting until the patient arrives to try to do that in just a couple minutes. So prior to the scheduled visit, remind patients to bring a current list of their medications to the appointment. If patients are resistant to that idea, maybe you can have them take a picture of their medication bottles, or some practices have them bring in a brown bag with their medications to the appointment. So that was just one suggestion. As we've talked today about utilizing that pharmacist in the role of helping with patients' education around medications, performing some of the motivational interviewing with patients in regards to getting their more compliance with the medications, and if they're not compliant, why not, and working with them with getting a plan together and goals. And then involving those patients, making sure that they do feel involved with their plan as far as medications, and helping them really understand that medication part of the overall plan of their overall wellness. So involving the patients, handouts, posters, verbal prompts, messages in between visits whenever possible, utilizing all the various roles in our care teams. Kind of what Lisa talked about how valuable it is to have multiple people involved in the care of our patients. And then this last bullet point of being militant about consistency, it's vital for proper medication reconciliation to ensure that what you have in place is followed as much as possible without fail. The more consistency and routine that we have in addressing the medication reconciliation or discussions around medication compliance and questions or education, the better, because it'll help us to move forward in addressing these in the new and creative ways that we have available to us now. So just wanted to share that. I know, this is really, these bullet points are centered more on best practices around medication reconciliation. That's such an important part of all that we're talking about here, of integration of the pharmacist into the care team. So we know that's so important for their ongoing care. Also particularly important during transitions of care, such as discharge from the hospital or from a skilled nursing facility, or from a primary care provider to a specialist and back. Just extra slide and extra reminders, and maybe a couple of pointers that you might not have heard before in regards to best practices around medication reconciliation. So any questions on that information that I just covered? We can go ahead and move on to the next slide, please. So for this, we have a list of resources that are available to you. We will have these slides available and being sent out after the Learning Collaborative, so you'll get them early next week. But what I wanted to do was just talk about the different things that are here, the resources, and give you just a quick description of what's there. So the first bullet point there is a description of the plan for monitoring compliance and checking with the prescription monitoring program. So all of these give you kind of all of these resources. We're trying to give you the kind of source documents or assistance for helping to understand why we do what we do around incorporating pharmacists and accessing the PDMP and doing reconciliation of medications. The second bullet point here is a video from Gary Garrity, and he was a speaker for us a while back. Some of you may have attended, and he talks about the prescription monitoring program. It's a great video. It's 50 minutes long, but full of really useful information. We've been accessing the PDMP for a while now, and thankfully a lot of us have electronic health records that we're able to utilize to directly access without having to go out of our EMRs and into the separate program. But this is a great, very informative video, and we wanted to provide the link for you here. The third bullet point is just the required Hedis and CAPS measures so giving us that background, and this is for 2021. So just taking a look at those will give you a little bit more explanation and how what we're covering today ties into those measures. And then the last one is some California requirements, just FYI for medication profiles that we thought would be useful for you to have. And next slide, please. This first resource is one that I think a lot of you are quite familiar with, but we wanted to go ahead and open that one and make sure that we jog your memory on that, because this is kind of a resource that we really need to be checking back with on a periodic basis to make sure that we're compliant with what our state has dictated for us in regards to prescription monitoring. So I think it's done pretty well, and just want to make sure that you see it so that you realize that it's there and or remember in case you haven't done it. So if we could go ahead and open that, Brittany, if you're able to. And so this is like the actual website for looking in from the Department of Health. Okay, and then we'll go back to our slide. Resources continued. So there's a link to the program overview for the prescription drug monitoring program. There's a meaningful use requirement, and last, another description of the meaningful use requirement around medication reconciliation. And lastly, the Healthcare Authority Medicaid drug utilization review requirement. So just helping you guys keep that background of, understanding the requirements around what we're doing. And we really want to come alongside all of you as you endeavor to meet the requirements that are asked of you. So just giving you some resources around that. Sam gathered a lot of these for us, and so just want to offer an opportunity for Sam to speak to any of the resources that she included that I may not have covered.
No, I think you did a great job. I think the most important one is the one that you covered. And again, going into really looking at, especially for prescribers and for pharmacy, into, can we actually pull that particular one up for the new Apple Health?
Is that the last one, the HCA Apple Health? Brittany, the last bullet point on the second page of resources.
It's a PowerPoint presentation. If she's unable to do it, that's okay. I just think that I just wanted to touch base if that's really important. It goes into great detail on the October 1st changes and the timelines, and go down towards the bottom there. I just want to show them where they can actually see it towards the bottom. And keep going down. Keep going down. It's the PMP rules slide deck, right where resources are. Oh, back up just a little bit. It's hard to find, so that's why I wanted to make sure that we pointed that out.
That one.
And then this will go into great detail. And like I said, there's a lot of great information on timelines, what's expected, the process, when you can expect to get the updated provider information sheets from the Healthcare Authority. And then the other references are just great all around, reminders, and to also just to cross apply all the different CMS services, your state, and all the different mandates that the PMP actually holds for you, and making sure that you're in following that guidance, as well as being making sure that you're doing your documentation, your processes, and that it's part of your everyday flow for medication reconciliation. Okay. Thank you, Brittany.
And if anyone has questions about that, as you meet with your navigators, we can look at that together and help you go through it if you need to. Like I said, I know a lot of you are already well aware of all of these requirements that we've listed in our resources, but it's nice to have them all in one place. Thank you, Sam.
You're welcome. Thank you, Laura. And if
Go
there's
to the
any
next slide. Are we ready to go to the next slide?
Yes. Okay, and if we can, I just want to make sure that nobody has any closing comments and or recommendations for our navigators, as far as what other resources that we could provide, or helpful information as far as being able to research that and bring it to your organization.
I do want to thank all of the people that participated in the panel today. A big thank you to you guys, and also to Lisa for your impromptu participation and being part of the panel there, and sharing your insights with us. So I want to say thank you to all of the panelists that participated today.
Yes, definitely. Thank you. And I really appreciate the correspondence from the audience. It was really good information. And also our connections, right? So if there's anyone that during this, the whole panel presentations and information that you need more and you would like to get in contact, definitely reach out to your navigator. So at this time, if everyone would go into the Survey Monkey and go ahead and fill out the survey.
And the survey link is on the chat as well.
Thank you, Martine. Carol, Diane, do you have any closing comments?
This has been a great sharing of information. I join everyone in thanking our panelists and their willingness to tell us, you know, what your secrets are and some of the challenges that you have. Integration work, whether it's integration of pharmacy or behavioral health or any other types of integration, is hard work. And just because the state has, you know, made this mandate of bidirectional integration, it doesn't happen without those relationships that are built between each other. So we just thank everybody for being willing to share and be on the line today for a long Friday afternoon. So thank you.
Carol, Diane,
Yeah, we had some confusion, so sorry if you clicked on that first link, it wasn't the right one. So we're gonna get the correct, I think Chelsea has put in the correct survey link. If you could please just take a couple minutes.
Diane just posted it
Oh,
into the
Diane.
chat. Mhm.
We
Chelsea
got
did
it.
too. So either one of those work. But thank you so much for everybody who attended today. I think it's really great that these learning collaboratives, we really rely on you guys to help provide the content. And we really think that learning from each other is the best way to go. And I think we're at a point in the transformation project that has given us that opportunity, is to learn from each other. And that is the part that I love the most about these learning collaboratives.
Thank you, Diane. Okay. If we have no more comments, and navigators, if you don't have any more comments to make at the end of this, then we will give some time back to our audience today and our panelists. Everyone have a great weekend. Be safe.
Bye.
Mask up.